talk I will speak about the description of the normal anatomy using B mode and color Doppler and also 3D, and I will do special focus on the early fetal echo. The basis for the normal fetal echocardiography is a so-called segmental approach, as you have heard before, and we start with a sweep from the transducer from the upper abdomen, and we go through the four-chamber view to the great vessels, and you see the offset of the AV valves, you see the ventricles, the atria, and you see also the course of the great vessels, and both arches are on the left side of the trachea. The first plane for the normal fetal echocardiography is the upper abdomen, and it is very important to know the position of the fetus. Is it a vertex or a breech presentation, and you know where is left and where is right, and you know that the stomach is left, the liver is right, and the aorta is left close to the spine, and the inferior vena cava is more ventral and right to the aorta. Then we do a sweep from the upper abdomen to the four-chamber view, and in the four-chamber view you see the heart axis. You see an axis 45 degrees between the septum of the heart and the line between the spine and the sternum. You know the area of the heart is around 1/3 of the thoracic area, and there's a rule in the second trimester that the width of the heart is nearly the same in millimeters as the gestational age. When you look carefully at the four-chamber view, we have different structures in the heart. It is worth to know. One, we know that the left ventricle is building the apex of the heart. The only structure is lying behind the sternum is the right ventricle. The only structure is lying on the right side of the chest is the right atrium, and the left atrium is very close to the descending aorta. We can examine the fetal heart from different positions with a transducer as in an apical four-chamber view, which we usually use in teaching courses, but in our daily life often we have a four-chamber view coming from the side. In the right, you see it in the right clip. It's much better for examination of the ventricular septum because you have a 90-degree angle with the ultrasound beam and the ventricular septum, and late in pregnancy often we come from the back because the baby is lying on his belly and we come from the spine. This is the baddest position for examining the fetal heart. Looking carefully at the ventricles, we see the typical characteristics of the ventricles. You see the offset of the AV valves. You see there is a small gap between the tricuspid valve and the mitral valve. You see the moderator band in the right ventricle, as you have heard before. And when we go in detail in the ventricles, you see on the right side the papillary muscles going to the apex of the right ventricle, whereas on the left side they're going to the free wall of the left ventricle. And you can count the papillary muscles. You changed your transducer position, you rotate in this plane the transducer, and you have a short axis through the ventricles, and you can count on the left side. You see 2 papillary muscles. On the right side you can see 3 papillary muscles. One important tool we have in ultrasound is a Cineloop, and on the left video clip you see the normal frequency we have in our daily examination. On the right side it's in stick volume, and I reduce the frequency by 4. It is a much better image to examine the fetal AV valves. You see every AV valve with its open and closing movement, and there is a different in the quality of the pulsed Doppler wave. On the left side, we have always the aorta in our Doppler spectrum because, if you have heard before, there's a close relationship between the mitral valve and the aortic valve on the left side. On the right side, the tricuspid valve, there is no relationship between inflow and outflow tract. Then we go to the atria, and in the atria, we have different structures. We have a left and a right atrium, and one thing is we see the septum primum. This is a small structure between the foramen ovale flap and the crux of the heart. You see the foramen ovale flap, and you see also the septum secundum. One of the additional planes we have in fetal echo, you know these planes always from the papers from Kieserud, is a longitudinal plane, and you see the inflow of the inferior vena cava into the heart. For me, 3D helps to understand this normal anatomy, because when you look at this 3D rendered heart, you see the two ventricles, you see the two atria, and below the foramen ovale, you see the inflow of the inferior vena cava. And this is an image. At that point, I always understand the function of crista dividens, which divides the blood flow from the lower part of the fetus into the left and to the right atrium. The next step are the pulmonary veins. Often we examine the pulmonary veins using color Doppler, and you can do it for both sides. You must change your transducer a little bit. You must reduce the velocity because it's a venous velocity, and you have always turbulences in the fetal heart. But much better for the examination of the pulmonary veins is using the B mode. You need a very good B mode image, and you see the inflow of the two couples of the pulmonary veins, one from the left close to the mitral valve, and one couple from the right very close to the foramen ovale or the atrial septum. In the atria, there is a special structure called coronary sinus. You will find the coronary sinus when you have a tangential four-chamber view and you have a double line. There is a structure on top of the mitral valve. It's a normal structure. And sometimes if you have a left persistent superior vena cava, you have an additional vessels going back to the heart, to the sinus coronarius, and then you have a dilated sinus coronarius. Sometimes it looks like an AVSD, and this is one of the major differential diagnosis in AVSD. The use of color Doppler is always red is to the transducer, blue is away from the transducer. It is important to decrease the box of your color box so you have a very good quality. You must play with the persistence, with the frequency, with the velocity, so that you have a good image. And clearly you can see the diastolic filling of both ventricles, and there's no sign of insufficiency. What do we want to see with color Doppler? For example, cases like this, it's an AVSD, and if you have a good setting in your color, clearly you can see the so-called H form in AVSD, and these are the typical findings, but more often you see in AVSD the tricuspid insufficiency in an untypical position. From the four-chamber view, we go to the outflow tracts, and first is the left ventricular outflow tract, and keep in mind the aorta is coming from the left ventricle and going to the right, and you see the continuity between the ventricle and the aorta. It's in the B mode, and the next is using color Doppler, and with color, clearly you can see in red the diastolic filling of the ventricles, and in blue the normal blood flow into the great artery in the aorta going to the right side of the heart. Then you switch your transducer towards the fetal head, and you will see the overcrossing of the great vessels. First, the aorta is coming from the left, going to the right, and then the pulmonary trunk is coming from the right, going directly to the left. The pulmonary trunk has always a bigger diameter than the aorta, and the right ventricular tract shows us a directly course from the right to the left. You see the B-mode scan, the diameter of the pulmonary artery is bigger than the aorta. You see the pulmonary trunk, and right to the pulmonary trunk, the ascending aorta and the superior vena cava, and using color Doppler with a small color box, you have again the antegrade perfusion of the pulmonary trunk. One of the additional planes in the right ventricular outflow tract is the so-called short axis of the vessels. To examine directly the left and the right pulmonary artery, you must tilt your transducer a little bit, and you can measure the diameters. Both arteries have the same diameters. It is sometimes very important in the differential diagnosis of heart defects, and you see that the right pulmonary artery goes around the ascending aorta and the superior vena cava. The next plane we will examine is a three-vessel trachea view, and you see both arches going to the left. There's a rule: both arches have nearly the same diameter, and the vessel on the right is the superior vena cava, it's a B-mode image, and again we do the examination in this plane with color, and we must see in the normal case in both vessels blood flow in the same direction, either in blue or in red, depends on the fetal position. When you look at the arches, you see the normal blood flow in the ductal arch and the aortic arch in blue, and when you play with your color and you reduce the frequency or the velocity of your color, you are able to see on the right side a vessel in a different color going back to the superior vena cava as the azygos vein. It's a normal vessel, and you are always will find this in the second or third trimester of pregnancy. One of the additional planes we have in the outflow tract is a sagittal planes or parasagittal planes, and here is also the 3D or volume ultrasound very helpful. And this is a stick volume of the ductal and the aortic arch, and clearly you can see the aortic arch with the head and neck vessels arising from the aortic arch, and the ductal arch. Both arches have the same direction, and it is not really useful to do in screening longitudinal views of the arches, but in the differential diagnosis of some heart defects maybe is very useful. And one of the other additional planes we have in 2D, it's a parasagittal plane. We start with the aortic arch, and when you sweep with your transducer from the left to the right, you will see the azygos vein also in B mode and also in color, and you can see the course of the azygos vein going back to the superior vena cava. In this area, there's a very important structure describing in the last years in a lot of papers is the thymus. You will find the thymus in front of the great vessels, behind the sternum, and you see the three vessels, pulmonary trunk, ascending aorta and superior vena cava, and in front of these three vessels you see the thymus and how it looks like in the video clip. It is on the left side, you see it in a B-mode scan, and you see the thymus as a structure looks different from the lungs. And on the right side, I use the color, and I reduce the velocity of the thallus, and Palladini calls this as a tie box, and you have the thymus between the great vessels, the innominate vein, and besides the thymus, you have the mammarian arteries goes down at the chest. It's a normal anatomy. When you play with your transducer a little bit, you will find vessels behind the thymus. It's the so-called innominate vein, brings the blood from the left side back to the superior vena cava on the right side, and it's the background of the thymus. It's a normal vessel. Sometimes in cases with growth retardation, it will be dilated because of the centralization. The heart defects we expect maybe in examining the outflow tract are, for example, transposition of the great arteries on the left side with a parallel course of the vessels, or the tetralogy of Fallot on the right side. You can see in color that the epsilon shape of the color and the overriding vessels getting the blood from both ventricles. So this is a normal anatomy in the second trimester, and in the last years, because of the first trimester screening, more and more the anomaly scan will switch from the second to the first trimester, so the early fetal echo comes more and more familiar. And the first description about fetal echo, early fetal echo, are from Gembroch in the 19th, and then a lot of publications in the last 20 or 15 years. We know there is an association between the neurotranslucency and congenital heart defects. It is not so strong as expected, but we have an increase in knowledge and in ultrasound technology, and on the other hand, there's a big anxiety, and it's not to understand, because in my mind it is much more difficult to measure strange things like nasal bone or ductus venosus in the first trimester than examine the fetal heart, because the heart is much bigger than these structures. We start with a normal four-chamber view, 13 weeks transabdominally, and clearly you can see the two ventricles, you see the two AV valves, you see the two atria. It's smaller than in the second trimester, but it's a completely normal anatomy, and you will find again the typical structures I described you before, and you have heard in the talk before from Giuliano Cavallo. Then we use color Doppler. And on the left side, you see the diastolic filling of the ventricles, and on the right side, you have the left ventricular outflow tract with 13 weeks, both transabdominal scan, and you see how the aorta are coming from the left going to the right, and then we have the sweep of the transducer going to the three-vessel trachea view, and you see the course of both arches, both in the same color, both going to the same site, and the size of the arches are the same as the size of the side of the apex of the heart, both on the left side. In special question, we can do also the fetal echo transvaginally. And of course, because we are very close to the fetal heart, the quality of the image is much better than transabdominally. And there's written 13 plus 5 weeks on the video clip. And if I didn't read this, and it looks like a video clip with 22 weeks. You have the both ventricles, you have the two atria, we have the two AV valves, and maybe sometimes you have the impression you see also the pulmonary veins, but never would speak about this. And in the small video clip you see for chamber view coming from the side, and clearly you can see the ventricular septum. Then we go to the color, and you see the diastolic filling of the ventricles, and also the right ventricular outflow tract and the three-vessel trachea view with 13 weeks. And again, I talked about the thymus and the arches, and this is an image very similar to the video clips I showed you in the second trimester, with in B mode with harmonica. You see the blood flow in the vessels, and you see both vessels on the left side, and in front of the vessels you see a normal thymus. The thymus is smaller than in the second trimester, but this is normal development of the fetus. We are able to detect heart defects in the early pregnancy. On the left side, you have a critical aortic stenosis with 13 weeks, with no contractility in the left ventricle, and later the fetus developed in hypoplastic left heart syndrome. And on the right side, you see a typical example of an AVSD with these AV valve in one plane. There is no gap between the mitral valve and the tricuspid valve. And also with color, you need very good color in early pregnancy. You see normal diastolic filling of the ventricles and parallel course of the great vessels in blue, both coming from the right side. And on top you see both arches going to the right, so double outlet right ventricle, right aortic and right ductal arch, normal chromosomes. So, and the last is we go to the 3D. 3D is a very good tool in fetal echo, and we use 3D especially for teaching and for understanding the normal anatomy, and also for discussing second opinion with a pediatric cardiologist, because sometimes we create with 3D images which are more familiar for the pediatric cardiologists than for the obstetricians. This is we cut these heart by half. We look at the heart and you see the ventricles, the AV valves, and the atria, and also the inflow of the pulmonary veins, and also the inflow of the inferior vena cava below the foramen ovale. Then we do a stick volume in combination with color, so-called glass body mode, and in red you see the diastolic filling of the ventricles, and for a beginner it is very easy to understand how the overcrossing of the great vessels works. The aorta coming from the left going to the right, the pulmonary trunk coming from the right going to the left in blue, and this is normal anatomy and normal physiology with 28 gestation a week. And you explain in 3D volume as a multiplanar image, and in these three images you see in red the diastolic filling of the ventricles, and on the left the left ventricular outflow tract, and on top of the four-chamber view the right ventricular outflow tract with both arches on the left side. One of the new tools in 4D is the so-called VCIA. Yesterday you have heard in the brain a lot of things about VCIC. You have a thickness of an image, you have a more contrasty image, and you can do the same for the heart, but not in the C plane, but in the A plane. Always I use a thickness of 2 or 3 millimeters, and you can perform in 4D online, not as in stick volume, online during your examination, and you see a more spatial impression of the fetal heart. You have the bigger clip is from the second trimester, and you see a complete fetal echo with all the description of the normal anatomy, and the smaller clip is in the first trimester, 12 weeks plus 1 day. And always I like to use it in the first trimester because you have a summation effect of this VCIA plane, and you have a better image quality in the first trimester. From the pathologist we know such strange things like heart ears, and the stick technology allows us to see the heart ears. This is in stick volume displayed in inversion mode, and you see the heart ears and also the overcrossing of the vessels. And sometimes we use technologies like this in the differential diagnosis of fetuses with heterotaxy syndromes. And the stick technology allows us also new planes. First, we have on the left side you have a four-chamber view, and when you rotate the four-chamber view via the x-axis, we look from below at the AV valves, and you see clearly you have two AV valves on the left side with 2 leaflets, on the right side with 3 leaflets. The right video clip shows us an image which maybe looks like a normal four-chamber view, but when you look carefully, there's on the right side it looks like only a membrane. You have some paradox movement of the ventricular septum, and when you rotate the volume again around the x-axis, we look from below at the level of the AV valves, and clearly you can see there's in this place we expect the valve. There is no valve because it's an Epstein's anomaly, and we have only the mitral valve on the right place. On the right side there is no valve because we have a very deep insertion of the tricuspid valve. And we use especially this tool in heart defects, and I showed you in 2 examples. This is a typical AVSD with 22 gestational weeks. On the left side, the normal 2D image. On the right side, the surface rendered images using the stick technology. And you see the typical pattern of this balanced IVSD with this common AV valve, and the AV valve is in one line. And when we rotate the volume via the x-axis, in the normal case, we will expect and we will see two AV valves, but in a case with an AVSD, you have only one AV valve, and you see also only the movement and the open and closing movement of this one AV valve. And again, the same for a case with an Epstein's anomaly. The normal, the typical 2D video clip, the typical stick video clip rendered in surface structure, and then I rotate this video clip via the x-axis, and we look from the ventricles at the AV valves, and you see on the left side we have a normal leaflet with two leaflets, and on the right side there is no AV valve because the tricuspid valve is not in the same plane as the mitral valve. And we can use volume ultrasound also in the outflow tract, and it's in stick volume displayed in minimum mode. Minimum mode means we do focus on the fluid-filled organs, and you see on the left a transposition of the great artery, parallel course of the vessels, but both coming from different ventricles, and on the right side you see also parallel course of the vessels, but both coming from the right side, double outlet right ventricle. And this helps us in the differential diagnosis of heart defects. The referral in this case was a right-sided aortic arch. I displayed this volume in minimum mode. You see both arches, the aorta is on the right side. On top you see the superior vena cava and the ductal arches below. But when I play with the volume, clearly I can see in a different plane there's a tiny vessel coming from the right, going back to the left, so we have not only two arches, we have three arches, a double aortic arch with a normal developed right arch and with an underdeveloped left arch. And we use multiplanar imaging also for teaching. Often people have problems understand heart defects who have a normal four-chamber view but abnormal great vessels, and clearly you can see in red normal diastolic filling of the ventricles, but when you go to the outflow tract you see parallel course of the vessels, both coming from the right side, double outlet right ventricle. And a next example is the also in severe heart defect, we have a normal four-chamber view with normal diastolic filling. We have an overcrossing of the vessels, but when you look carefully at this video clip, the apex of the heart is on the left side, both arches are on the right side. It's a right aortic arch, it's a right ductal arch, and if you look more carefully at this heart, you will see the vessels are close to the sternum, there is no thymus, and it was microdeletion 22. So we come to the conclusion. First, we do a segmental examination of the fetal heart, and it is very important to know heart rhythm, insertion of the AV valves, and also the ventricular proportion in the structures. Then we search for the course of the vessels, the overcrossing, we check for the thymus, and when we go in early pregnancy, it is important to check for four-chamber view and three-vessel view with B mode and with color. And maybe you use 3D or 4D for teaching, second opinion or counseling with pediatric cardiologists. Thank you.